Okay. So did you put yours? Did you just hook in? Yeah. I saw it.
This is from like early high school.
Do you have a clicker?
Yes.
Okay, good.
All right, so I did fecal transplants, clearly. Clostridium difficile. C. diff is a gram-positive bacteria that causes a number of issues, including but not limited to pseudomembranous encephalitis, gastrointestinal disease, foul feces, endospores, and toxic megacolon. The elderly and immunosuppressed people whose bodies can't reproduce the normal flora can even die from infection. Feces can be transplanted as a treatment for severe C. difficilitis. C. diff typically results from an antibiotic therapy which kills good bacteria in the process of killing bad bacteria. The two most common treatments of C. diff are flagell and difficid. A fecal transplant, which is also known as fecal bacteria therapy or HPI, which is human probiotic infusion, is the process of restoring the bacteria commonly found in the digestive tract with an infusion of feces from a donor. Yes, this sounds kind of gross, but having bacteria is important in the digestion of our food, and when bacteria in our digestive tract gets destroyed, it's incredibly hard to get back. The process. So basically, you're given enemas, which is containing the donor feces, to those suffering from the bacterial infections of the bowels, like C. diff. The theory behind fecal transplants is to combat bacterial infection in the colon with harmless bacteria in an effort to get rid of the pathogenic microbes, restoring the natural harmony. Donors are typically family members, and the feces is thoroughly tested to make sure they don't have any bacterial, viral, or other harmful infections. It can be administered up to 5 and 10 days, but usually the first one takes effect. A study published in the New England Journal of Medicine proved a 94% cure rate in those treated with fecal transplants, compared with a 31% cure rate with vancomycin. Another thing you can do is ARGF, which is autologous restoration of gastrointestinal flora. If you don't yet have like an infection from the C. diff, but you're more at risk for it, this is the better thing to do. Basically, you give a stool sample, which is then refrigerated, and if you do get infected with the C. diff, the sample is extracted with saline and run through a filter. And the filtered material is freeze-dried and encapsulated in little capsules. And you swallow those, which helps restore the normal flora. Review questions. What bacteria is at fault for the most fecal transplants? Clostridium difficile. What other terms do people call fecal transplants? Bacteria therapy or HPI. What are the two most common treatments of C. diff? Flagell and difficid. What's an option for those at risk but not yet infected? ARGF. And then my works cited.
Doesn't it sound a lot better to say human probiotic infusion rather than fecal enema?
Yes, it does.
Like that's just how powerful words can be,
I
right?
think it's just amazing that someone created that, came up with that, and did other people.
But also the idea that if you think you're really at risk of developing and giving your own sample, the autologous sample is just a great idea too. But a lot of people, I mean, can you imagine if every patient that's been on antibiotics somewhere in the world, they were storing stool samples for them? That would be a lot of storage space needed, right? But thanks, Jenna. Y'all have any questions, Jenna? Y'all have any questions? Jenna, did you or it was Brittany, right? Brittany, see that?
No, I didn't print it.
No, I'm sorry, Rebecca. I know. Oh, so did either of you see a megacolon? Did you see any pictures of a megacolon? If y'all just have a second to Google something and see what can happen to someone's colon, when they say megacolon, they are
literally a megacolon.
It is seriously like there's no going back, right? So this is a serious consequence that can happen from C. diff infections. Thank you.
So
very
when
much.
you go,
And thank you, Rebecca. So that was sort of a tag team there approach. I probably should have, we should have probably tried to do that back to back, but that's great. You next, Hilda? Painted off
yeah.
road.
He might burn because he looks painted.
He is painted.
He looks pink. Is that right?
No, not burnt. My arms not burnt.
I'm pink right now.
No, they're not red. Well, they're red right now, probably, because I don't like talking in front of people. But did you use your flash drive? Okay.
The other little thing that's in there is actually the clicker. That's the little drop for the clicker, Dakota.
Okay, I thought it was.
I'm sorry. And the slideshow. You just take it out. Wait a minute, wait a minute. I think you can just go over it if you want to, because I'm afraid that would
Go
cut
to
off.
file and then go to open.
And I'll just be on top of it, it's fine. Like I know anything about technology.
You said. Item 9, presentation on wound care. What is wound care? And first, specific types of treatments for wounds that break the skin. My case file, it started with the LPN. She has just started working in a hospital. Her job was to assist physicians with suturing, which is basically what we call stitches. During the spring, they had a lot of farmers because they were in a rural area. They came in with cuts on their lacerations on their fingers, legs, arms, all that. The first physician she worked with asked her to prepare with betadine. So she did, and then she worked, I don't know how many days later, or it was the same day, but she worked with another physician, and when she set up a tray with betadine, he was kind of mad with her. He didn't want betadine, he wanted sterile saline. So then she went to her boss and told her about the incident. And she was like, yeah, she felt bad about it. She was like, I'm sorry, I didn't let you know that some physicians around here had different methods. And then she told her to research between the two, like to see why they think it's better. She found out that aseptic use has a goal of destroying bacteria with the wound without slowing or stopping the healing process. Antiseptics can reduce the bioburden, which is the amount of harmful bacteria, but it also affects the healing of the wound and can be toxic to the healthy human cells. She also found out that studies have shown by using antiseptics they can cause adverse effects on wound healing. She also saw that the authors are now recommending sterile normal saline for the use. The U.S. Agency for Healthcare Research Policy says not use povidone, iodine, which is betadine. Iodophor, sodium hypochlorite solution, hydrogen peroxide, and acetic acid, as they've been shown to be cytotoxic, normal saline, at a pressure between 4 and 15 pounds per square inch. The benefits of normal saline is isotonic and it makes the wound cleansing less uncomfortable when it is combined with irrigation, which is a syringe with a needle or a pulse lavage. The bioburden is diminished just as the same as with the anesthetic, without it being cytotoxic. If you're asking what irrigation is, it's a steady flow of solution across an open wound surface to achieve wound hydration, remove deeper debris, and assist with the visual examination. It's meant to remove cellular debris and surface pathogens. Just a basic wound care technique. You would assess the patient's condition and identify he or she's allergies. You look at the wound and see if there's see if it's draining, the size, the condition of it, and the surrounding tissue. Make sure you wash your hands, put on clean gloves and wear a gown and goggles if it's needed. If there's a soiled dressing, remove and discard with the gloves. Probably wash your hands again. Irrigation should be performed using a strict aseptic technique. Aseptic means free from contamination and harmful bacteria, viruses, and microorganisms. Then you would apply clean, neat dressing. There's varies by technique, what type of irrigation you use. This is a piston syringe technique. Some of the equipment is like an emesis basin, of course your clean gloves and sterile gloves. You would need a 35 milliliter piston syringe with a 19 gauge needle or a catheter. That's just a whole lot. Also, types of wound dressings. There's gauze sponge. You can use for all wounds. Gauze bandage roll. You can also use for all wounds. Non-adherent pads. It's used on lightly exudating wounds, acute wounds and skin tears. The non-adherent wet dressing is used on light, moderately draining wounds. Great for burns. Foam dressings used on moderate to severely exudating wounds. Great for pressure injuries. Calcium alginates used on all moderate to severely exudating wounds, great for venous and arterial ulcers. The hydrogel dressings used on dry to minimally exudating wounds with dead tissue, and transparent dressings used on those severe later. What does bioburden mean? She said the amount of harmful bacteria. What is another name for sutures? And then what does aseptic mean? Correct. And we're excited.
Your hair color is so handsome. Thanks, Dakota. And you know that whole, that's kind of like the old school. Y'all are going to just see it all the time and be in it all the time. We will have, because you are the primary care providers, you are the ones doing wound dressing, you are the ones doing whatever, but you'll be having different jobs and different whatever over you. So some of them will be old school, some of them will be new school of thought, you know. Sometimes the old school and new school are just 6 of one, half a dozen of the other. But in this particular case, there was really legitimate reason for going to the isotonic saline solutions, and that is more of the recommended solutions because of the lack of the cytotoxic effects. So that could have all been avoided if that doctor had just taken a second instead of being snippy and just explained to the nurse, right? Instead of there being an incident. But guess what? A lot of times it's not going to, that's what's going to really happen on the floors, isn't it, Janet? I know.
Doctor.
What'd you say?
I said, doctor, these people's above me. I was like, you should have told me. You didn't tell me. I just assumed.
You think that you're over. Thank you, Dakota, for bringing that topic. All right, who is next? Me. He's back there with your clicker. Okay. No, thank you.
In the cardiac, or in the line of the heart valve. So my case file was on a 22-year-old named Donna. She basically came, she's a college student. She came home a month before to visit her mom during Thanksgiving break. So during her time coming to visit her mom, she went to the dentist and had extraction done. After the dentist appointment, everything was fine. She healed up and what she thought she did. Went on back to school. She was basically studying for her exams. So during that time, she wasn't eating right. She was drinking a lot of coffee and had been calling her mom complaining of not feeling well, that her joints was hurting. And she felt weak. She had fever going up and down, and she just kind of brushed it off. So she came back home a month later, which was interesting. And her mom told her she told her she looked like she lost weight, and she didn't look well. So her mom took her to the ER. Doing the nurse checking her over, examining her. Her temperature was 114. Her heart rate was abnormally fast. It was 112 beats per minute. Her blood pressure was low, 95/62. Her oxygen saturation was 93%, which was very low for someone her age and condition. Her lungs were clear. When listening to her heart, the doctor detected her heart. A heart murmur is like an unusual beat of the heart. It's generally like a swishing sound. So she asked her mom about the heart murmur. Her mom told her that that was detected at birth, and the doctor told her not to worry about it. It was fine. The nurse noticed that Donna was pale. As she was checking her fingernails, she noticed that she had dark brown lines running vertically on her fingernails. She also noticed that she had like spots all over her palms, like purple red spots all over her palms. So when the doctor came in to check her, he noticed the same thing, the spots, the heart murmur, and he ordered an echocardiogram, which didn't get pictures and stuff of her heart, and he ordered blood cultures to check for any pathogens inside of it. Okay. So endocarditis is the inflammation of the epicardium, or the inner line of the heart, mostly occurring to the mitral or aortic valve. Infectious endocarditis has been described as being acute or subacute. How is this contracted? Endocarditis begins when germs enter the bloodstream and then travel to the heart. Germs are mostly likely to enter the bloodstream through central venous access lines, injection drug use, or unclean, unsterile needles, recent dental surgery, or other surgeries, or minor procedures like dealing with the breathing tract, urinary tract, infected skin, burns, and muscles. Bacterial infections is the most common cause of endocarditis, known as bacteremia. Endocarditis can also be caused by fungi, such as cancer. In some cases, and also by viruses. In some cases, no cause can be found. In this instance, Donna was diagnosed with subacute endocarditis. The signs and symptoms are very similar for both types of endocarditis. The subacute differs due to the conditions developing very slowly and unnoticeable with the acute. Some signs and symptoms could be fever, fatigue, joint pain, edema, swelling in the feet, legs, or abdomen, weakness, anemia, and symptoms similar to like someone could be feeling like they have a heart attack, shortness of breath and chills. Abnormal heartbeat, petechiae, which is small red purple spots present on the upper half of the body on the fingers, slithering, Oscar's nose, and Janeway lesions, which is red pain, skin spots, and palms and shoulder. This is some pictures of Janeway lesions and splenic hemorrhages and Oscar's nose. Positive agent. Most common causes of acute endocarditis is caused by bacteria with low pathogenicity. In most cases, derived from the oral cavity. Causative organism is the alpha-hemolytic streptococcus. Is the most common cause of endocarditis after dental or medical procedures.
And that alpha-hemolytic streptococcus is the inner coccus group. So that's where y'all had inner coccus on there that included some of those less virulent streptococcus. I didn't mean to interrupt you. This is really good. Okay, I'm sorry. Go ahead.
The most common mode of transmission, endogenous transfer of normal bowel to bloodstream, meaning that it's born originated from a side organism. One example, overly vigorous toothbrushing, dental procedures, minor cuts or lacerations in the skin can introduce the bacteria in the skin. Diagnosis is generally a blood culture checking to see if pathogens are present. Prevention is prophylactic antibiotics before invasive procedure. For an example, before some clinics administer immunization shots to babies, they would sometimes give them Tylenol to help with pain or fever that could lead to effective immunization. Or going to the dentist, they'll give you sometimes pain. Treatment, sometimes surgery is necessary. Case by reference. In Donna's case, when she was a child, her heart murmur was detected. And it was overlooked. It was later determined to be a congenital abnormality of the mitral valve, which is confirmed with that. So when Donna went in to have dental work done, it introduced the infection to her bloodstream, affecting her mitral valve. When her cultures were completed, it indicated she was positive streptococcus and was diagnosed with subacute endocarditis. Donna was not aware this was happening inside her body. It was subacute endocarditis having slow onset. She was treated by giving antibiotics through an IV, going straight to her veins, and eventually had to undergo surgery to Trachomatis. The question is, what are the two types of endocarditis? What is one way of transmission? What are the treatment methods?
Really sad that that 23-year-old had to have a mouth brace. Guys, that's not good. You know, it's a really sad thing. And most murmurs that are detected congenitally that, you know, have been there since birth are benign. But if somebody does have a murmur that sort of stays present that you can hear, they should always be treated prophylactically with antibiotics before an invasive procedure. So that was kind of missed for her, wasn't it?
Especially having a heart murmur and the doctor says nothing wrong.
Yeah, yeah. No, I mean, you know, things happen, but yeah. Wow. Yeah. See, but that's all. It's just sitting there, just open up the top down here. Camouflage.
I think it's not like
There it was.
that's not frequent. That's yours, not mine.
We should have just always let y'all run class. Kind of like it sitting right there. Here's the. Thank you.
All right, so I picked the Chapter 12 case file, which at the time there was not many, but this actually ended up being that pretty interesting, which it's on the bacteria, I believe it's Helicobacter pylori? Helicobacter pylori. Okay. Now, the patient was a 20-year-old college student, like the majority of us in the room here. Her name was Natasha, and she showed up for a gastroscopy because she was experiencing persistent stomach pain. Now, the stomach pain had been going on for about 5 years, on and off, in bouts that every 4 to 6 weeks, which kept her from going to class and work. And during the pain, she was experiencing intense hunger, but the pain worsened as soon as she ate, which I also read that she managed to avoid eating for about 5 days at a time because of this. Yeah. Now, when she showed up, oh wait, I skipped one, didn't I? No, I didn't. Now, when she showed up, she was incredibly dehydrated and she was weak along with the pain. She had an elevated hemoglobin level because of dehydration. Her white blood cell count was normal. She didn't have a fever, and her epigastric area was tender when palpated, and she had an increased heart rate, most likely due to the pain. Okay. The doctors consciously sedated her, and the back of her throat was anesthetized, and the gastroscopy scope was run down her throat, which I don't know if any of y'all have had that done, but it's really sore afterwards.
You got it?
Yes, I have. I was sore for, I think, 3 days. Yeah. The esophagus looked normal. However, the patient's stomach was inflamed, and there was evidence of several healed ulcerations, along with one ulcer that had not healed. They took biopsies from the inflamed areas, as well as photographs of the lesions, and they took the scope out. They gave her medication to reverse this sedation, and she was sent home after being fully recovered. And they made a follow-up appointment approximately 1 week after that. The biopsy results showed that Helicobacter pylori was present in her stomach, and it was deemed as being the cause of the ulcers. They gave her antibiotics and an acid reducer, and they scheduled a follow-up appointment to be sure that the treatment was effective, which it was, by the way. Now, quick little thing, do any of y'all have a guess as to why Helicobacter pylori didn't die in stomach acid? of the stomach? Huh? Okay, I was just asking to see if you had any guesses. Now, Helicobacter pylori is gram-negative, so I believe that means it pops as pink. It's estimated that about half the world's population actually has this, and it's just asymptomatic. It shows symptoms in about 20% of the people who do carry it. And these symptoms can include, not limited to stomach pain, bloating, belching, and nausea. Now, as to that answer to that checkpoint thing that's there, it can survive in the acidic environment of the stomach because it uses its flagella to actually burrow into the mucus lining of the stomach to get away from the acidity. It uses chemotaxis, I believe, to be able to tell where the acid is and to move away to a more neutral area. And it can also excrete an enzyme called urease to neutralize urea in the stomach, which breaks it down to ammonia and carbon dioxide, which the ammonia actually counteracts and neutralizes some of the acid in your stomach. So, yeah, I forgot to warn y'all, I'm sorry. Gross picture. Now, Helicobacter pylori does elicit an inflammatory response in the body, which causes the stomach to produce more stomach acid. Now, this excessive stomach acid is the cause, typically, of the ulcers. So it's indirectly causing it, but it does cause the stomach ulcers, which... Treatment for it typically involves antibiotics, which I believe they double you up on amoxicillin and clarithromycin, I believe. Okay. And they also tell you to take or prescribe you proton pump inhibitors, such as the Prilosec down there, to help with the excessive acid. And this type of therapy is usually called triple therapy, and it's very effective at getting rid of Helicobacter pylori. I do have a pop quiz, which I don't want to pull it up because the answers are right on there. But what's Helicobacter pylori classified as? Yeah, bacteria. And how does it know if or when there's a highly acidic environment around it? Chemotaxis. Yeah, that thing. And there's the answers. Are there any questions? Oh, okay. And there's my website.
Well done, Siri.
So now you can share with us why you had the procedure.
I'm sorry?
Now would you share with us why you
Yes,
had
I
the procedure?
actually-
Is that too personal?
No, it's not.
Were you being tested for ulcers?
I actually did have ulcers. Yes.
Oh, you did?
Yes, I did. Not because of this, which I thought was kind of around because I'm again taking this one, which I didn't know was about ulcers. But I one day I actually caught a flu, and it was actually on Halloween. I was upset because I didn't go get trick-or-treating, and I caught a flu, fever, and all that. And my mom gave me 3 ibuprofen. And me being a kid who was sleeping, I took one tiny little sip of water and went back to bed. And the next day at school, I was struggling to get to the nurse's office because I was dizzy, falling over myself. I was dragging myself to the nurse's office. And they did the gastroscopy and found out I had 3 nice little ibuprofen-sized ulcers in my stomach.
Oh, wow.
So, yeah, I think my mom said my red blood cell count was 7.
So evil.
Yeah.
That's scary, isn't it?
It didn't hurt. I was just incredibly dizzy. Very.
You were bleeding.
Mm-hmm.
Yeah, that's worse than hurt.
Yeah.
It's not. We're done. Well, thank you for sharing that with us. Did you read anything about the breath test that they can do for Helicobacter pylori?
I actually did not. No.
Looking at that because it does have the urease that breaks the urea down. They can do the ammonia urease test from breath. So sometimes it can save people from having that procedure done. I don't think it's enough for some, but the testing that they do is sensitive enough that it can pick pick up if somebody has higher levels than they should be having, because it would be from the breakdown products of that microbe.
I also briefly read that urease is like a skin and nail product as well. Yeah, I think it can help with some things. I don't know. I didn't read
It's a
too
very,
much about
I mean, we have urease,
Yeah.
so we have that in our system, but it's just after a certain level detectable in the breath, then they think it's only coming from that microbe and its byproducts. So that would be a lot easier to test than having the scope done. But sometimes they need to do the scope because of the biopsies.
Yeah.
Well, thank you, Jared. Thank you, Janet.
I just went old school on it.
Okay.
Yeah.
So,
old school.
so we're not needing to type into the computer like my poor self. Okay.
And I just, yeah, my,
Oh,
yeah.
that's not old school. That's good. That's good.
Conjunctivitis, it's an inflammation of the conjunctiva, which is the outer lining on the eyeball and underneath the eyelid. And there are many types. I'll just talk about a few, but I don't have that much time. Bacterial is way different than viral. Bacterial, you have a deep, funky stuff in your eyes may be glued together in the morning. You'll have a thick discharge. Your eyes are red, itchy. You'll be sensitive to sunlight or bright light. Viral, you'll have a clear water. It'll be red still, but a clear liquid will run out of it. There's allergic, which is kind of the same with clear, all red around your eyes. You can get it from contact lenses, not cleaning them properly. You can get it from chemicals, all kinds of stuff in the air, pollen. There's neonatal, which when a baby is born, comes through the birth canal, it can be infected with Neisseria gonorrhea or Chlamydia trachomatis, herpes simplex 1 or 2. There's also there's a list, a mile long, of things, bacteria and other causes. Main one that causes the Staph aureus. There's Streptococcus pneumoniae, Haemophilus influenzae, Pseudomonas aeruginosa, plus the gonorrhea and the trachomatis. Chemical contact lenses, dust mites, pollen, animal dander, and you can get that. And its treatment is depends on which type you have. You could either for bacterial an antibiotic, eye drops, and it'll go away on its own if it's viral, but it'll take a little while and you'll be miserable while you have it. And there's another kind too also, it's called giant papillae. That's the one that's caused by the contact. And that just looks terrible. Some of the pictures are just, the eye looks like it just turned inside out. Yeah, it just looks terrible. So anyway, 3 questions. Name 3 types of conjunctivitis. Right, and what are some of the symptoms? Name a symptom. Right, and name at least one bacteria responsible for it in newborns. Thank you.
Sometimes babies, I don't want y'all to freak out if you see a baby with bad conjunctivitis and think, gonorrhea. I don't want y'all to think that because that's not, that's not usually the case because there are eye drops here in this country. So, but babies get conjunctivitis quite frequently, little babies, because their tear ducts are blocked. And because their tear ducts are blocked, they don't get this nice rinsing and draining. So their conjunctivitis is just a normal inflammatory response. So, so please don't, the next baby you see with conjunctivitis, be thinking, did you test it for Chlamydia, Trachomatis, or Neisseria gonorrhea? Because it's a really common thing for babies to have blocked tear ducts. Yeah.
My little sister, I know, but the twins.
Yeah.
She had to have surgery on her, because of, she would wake up and we couldn't open. We had to take a warm rag and hold it over her eye just so it would
open. Yeah, because of the blocked up. Yeah. So I remember my mom used to say that we had cat eyes. Oh, goodness, you have cat eyes. Go get some warm water. You know, all right, I'm going. I was
What's the worst than animals? Animals just so bad, especially kittens.
yeah, well, that's why my mom would say cat eyes. I'm not sure what she would say that because we didn't never got that kittens. So they were in the barn. We didn't get to come into the house. So, all right, thank you guys. Y'all are doing a great job. Do we have anybody else that I'm? Jake, I hope you listen to this recording because you got way more attention than you would have gotten if you just come in here and done this thing. I know he did it because he said it to me. So anyway, put up. So, okay, well, presentation did count, so I appreciate you guys for playing. So has everybody got, everybody's got to do theirs, and you know, it's an opportunity because honestly, and we should look at things like that as an opportunity because really what we know is the best way that we do learn is by this type of discussion about these. Did I take somebody?
No, that was the one that's been written.
This is okay. I'm gonna let you all call it out to me. Did y'all do that? And I'll just stand here and sort of talk about this. You guys, so what we want to do is I can just sit with y'all. Thank you so much. Okay, look, I'm going to it because it's not like I have a screen up here anyway. So guys, here's what we're gonna do. We have one last test in here, and I talked about it on day one in this class. I don't know if you guys really recall day one, wasn't that long ago. But I said, you know, one of the most important things about microbiology, and I think that what happens in an undergrad microbiology class is a lot of times what you get in that class is molecular and cellular biology information over and over and over again. But for you all, y'all are going into health science fields, so this microbiology is really geared toward health science professionals because you're on the front lines. I don't care if you are, what you might be doing. If you're doing anything in a health-related field, you're kind of front lines. So it needs to be infectious disease oriented. And so the most important thing for you all to get out of this course are InVids. Now, I could have just given them to you on day one and said, see y'all in exam week, and hopefully you pass this exam, you know. But what people would have done is memorize it. Is memorization learning? No. So I do want to thank you again for your presentations because you, like the way you all presented this, especially in case studies, you sort of see the whole picture. You see like predisposing factors that contribute to whether somebody's going to have the disease or not, and how serious they're going to have, how serious that disease will actually be, and then thinking about treatment, proper treatment, because if we're not getting the proper treatment, sometimes you're actually doing harm. You get what I mean? So this is, thank you for this semester. I really want to tell you all that. I mean it. This last final exam, yeah, I guess I could even make it better by making it overbook and notes. I'm not going to because I'm just not. I'm still old school enough to think that most people will learn the most if they know they're under the gun and really needing to understand material and not just being able to find it in a book somewhere, right? So let's make sure that we get to at least talk out loud about some of these things we haven't looked at yet. So let's start with bacteria. And again, let me just, awesome. All right, so let me just say this. Some of the questions will be, and you will be paying attention to this on the question. It will say, which of the following is the most common bacterial cause of so-and-so? Should you be looking for bacterial, viral, fungal? Because in the multiple choice, it's all multiple choice, and the multiple choice answers, you'll be able to remove some of them because you know they're not bacteria. So please, let your understanding of that help you do these test taking things. Yes, Jared?
Are there any questions like which one of these is gram positive or something like that?
No. No, and no, because honestly, if I thought that you were going to become microbiologist, needed to know that, yeah, I would do that. But no, I'm not going to do like that. You know, of the bacteria, which ones are gram-negative, which ones are gram-positive. Do we understand that it means that they are actually different? That dictates the cell walls of those, and do we understand that they're treated differently, gram-positives and gram-negatives? So, you know, antibiotics work against bacteria, but at this level of y'all's understanding, you understand that not all antibiotics treat all bacteria, do they? Because some bacteria have a really thick cell wall, and some have a very thin cell wall, that peptidoglycan layer. That's making sense to y'all. You're okay. So, but no, at this level, no, you're not going to have to know that. But okay. So page 1, we feel pretty good about all those. We talked about them. Page 2, are we feeling? Well, have we
We've done
those?
them, yes.
Are you talking about the back of page 1?
The back of page 1.
Yeah.
So you feel pretty good. Okay, so thank you for sharing yours. I should have brought one in for me. So okay, so on this one that starts with Haemophilus influenza serotype B, there's Klebsiella pneumoniae. Klebsiella pneumoniae is in the Enterobacteriaceae family, and so it is a gram-negative bacilli. But the thing about this one is that when we've had this one isolated, especially from pneumonia or septicemia, I don't care if they are getting treated, they might not make it. That's how dangerous that one is, okay? Klebsiella pneumoniae. If you all see this one, you know if this comes back on the lab report, you're going to know that this is incredibly serious infection, and the treatment is going to have to be spot on. If you're not seeing somebody responding pretty quickly, then certainly there's going to be a discussion about changing that antibiotic, right? This calls for big guns, and you know I call them big guns. It's big broad spectrum antibiotics. But yeah, this calls for this is one that is very serious enough that even drugs that have a low therapeutic index, you're going to have to go with them sometimes. All right, Legionella Pneumophila, it causes what we call Legionnaire's disease. I don't know if you all have heard of this disease, Legionnaire's disease. It was called that because the first real outbreak we saw of this was a Legionnaire's conference in Philadelphia, I think. But anyway, probably 2 or more decades ago now. But these people were at this conference, and many of them came down with the respiratory-like illness that ended up progressing, and there were a couple people who died from it. And it took a while, using Koch's postulates, to figure out what was causing this. And we found out that this bacterium actually lives in vents and lives in some water lines. And so where we see it now are people who have maybe been in areas where they've been exposed to vents that aren't well ventilated, so you see moisture. Have y'all ever seen moisture in vents and they're spewing out? Have you ever seen vents that look like they're spewing out moisture? And also hot tubs even, it can be. So that's where this comes from. And it is a bacterium, so we can actually diagnose it usually through indirect serology, which is going to be an antibody test. You don't have to know that. You just have to know what's on here. I'm just telling you about it so you won't forget. Okay? Telling you a few more things about it. I know. I'll talk fast. Is there a class in here after this? After this?
Yeah.
They weren't even here. I'm going to ask them if they go somewhere else. I'm going to tell them they don't have a. Hey, look, I'm going to do that right now. Just there. Actually, when you do the paper, if you ask go down for Dr. George, if y'all could go to 29 music one, because this computer's not working anyway, so y'all need it. You know what?
I'm hungry.
Are you serious? Woo! Okay. Are you serious? That's so awesome. Thank you. Will you ask her, does she mind changing to 29? Because we need the room. Thanks. All right. Does she use? So she uses this. Does she use this?
I mean, you can talk her out of it.
All right. I'm gonna try to talk her out.
Okay.
Is there a lot? Are there a lot of people in here? Skull.
Yeah.
Okay, we're 29 over. That really will. That really will. So You guys, the weird thing about this one is that it won't grow in regular media. So like sheep blood agar or chocolate agar, you have to have like a potato-based agar. I mean, like who comes up with that? Okay, but anyway, that's true. So Legionnaire's disease, you will have heard of it. Syphilis. Have I really not talked about syphilis?
You really haven't.
Huh?
No.
Oh my God. Okay, well listen, guys. Syphilis is caused from Treponema pallidum, which is a spirochete. It's a bacterium. It's a little spiral-shaped bacterium. Treponema pallidum causes this disease. This disease is actually on the rise right now. There have been several epidemics in the last decade. Several in Lynchburg, Virginia. Richmond, Virginia is the syphilis capital of the country. So just let you know. I want you to let you all know that syphilis is really kind of tricky, because if you've ever heard of blood tests before people got married, y'all remember old days, people do blood tests before marriage? A lot of people, you've never heard of that? Y'all didn't know. Some states even still require it, and it might be coming back, not for marriage, because people aren't getting married as often. But the reason that they were doing that is because the people thought it was to see if they were type compatible. No, they were doing one test. It was for syphilis. That's the one test they did. It was it's called an RPR test. It's to test for syphilis. It's that common. Let me tell you, y'all should know about syphilis, and you should be aware of it. Syphilis is a disease they talk about like first, second, and third presentation. The first primary syphilis, what's going to happen is the spirochete, where it bores into the skin first, and it might be tactile, because it's this sex.
Yes.
Or it might be oral, wherever it bores into, or it might be in the genitals, which sometimes, it's hard to see. But wherever it bored into, there's going to be a painless ulcer. And when it's painless, and if it's a spot where the sun doesn't shine, will you even know it? So could you miss it? There's some people who come to your ER and they've got this ulcerative lesion. They say, no, this doesn't hurt, but look at this thing. Okay. So it's painless ulcer, right? Painless ulcer. That's primary syphilis, a painless ulcer. It can be weeks later, you have flu-like symptoms. How many people, after they've had a painless ulcer, that might have been where the sun doesn't shine, they never knew they had it, and a few weeks later they have flu-like symptoms and they think, oh, syphilis. Nobody. Nobody. So that's secondary syphilis, and you missed it. You missed it. Easily treated with antibiotics if you can catch the primary and you can catch the secondary, but you didn't. You missed it. So now, years later, that spirochete can go to the central nervous system and be a cause of dementia and eventually death.
I've heard of that, like the 70s and stuff, when people were really enjoying themselves, and then years later.
What'd you say?
Like when people were having a lot of unprotected sex in like the 60s and 70s or whatever, like peace and love and all that.
Are people only having unprotected sex in the 60s and 70s?
Oh, no, I'm just saying though, like that's like the peace and love, like, and they're at the older age where they're getting dementia. That's what I mean.
Oh, yes. It's absolutely true. There's a CNN special right now on 1969. I think it was going on 69. And if you even look at the previews of what was going on in 69, there's nothing new under the sun. Y'all might think you have all kinds of wildness. Nothing compared to the 60s. Okay, this is just nothing new under the sun. Don't let old people tell you that they didn't act that way. They did. So anyway, here's all.
Oh,
so here's what I just need you to know. So when you have anybody that comes into your ER that is showing any signs of confusion, what should be a test that you do? It's just blood work. It's looking for antibodies. It's an RPR test looking for syphilis.
So it's not treatable.
You can treat it. You're going to have to be aggressive treating, but it's going to be much more difficult to treat. This is also why that people need to have, like, I don't think you annually need to be screened for syphilis like you do for chlamydia, that's so common, right? Or even gonorrhea or some of the other diseases, but you do need to be screened eventually, sometimes. Okay, so anyway, syphilis. Treponema pallidum, make sure you know that. Helicobacter pylori, thank you so much. We got that from Jared today. Thank you. And see, y'all will remember, sometimes y'all will remember what you all said much better than you'll remember what I said. Gonorrhea vaginalis, I want you all to know, this, sometimes they're trying to change the name on this, but this causes what is known as bacterial vaginosis. So BV is actually what they'll abbreviate that as. That can cause a malodorous discharge that is fishy, smelly. Vaginal secretions should not smell fishy. And you know, sometimes you'll, you know, hopefully not in academic situations or whatever, but you would maybe hear something that's derogatory toward women and fishy smell, which is really uneducated because it means that the person is ill, right? So bacterial vaginosis can cause a frothy kind of discharge that is usually, if there's a malodorous discharge, then something needs to be evaluated because something's off. And this is not considered a sexually transmitted disease because most women have this as part of our normal flora, but it should be low in numbers where it's not causing any trouble. It's when the normal flora gets out of balance and this particular organism can take over and it ends up causing inflammatory responses that lead to that. Yes?
This is kind of really random.
Okay.
I was watching this like show on YouTube or whatever, and it had porn stars on it, and they were talking about how a lot of the women on there, they get BV and how it's like prominent, I guess, because I don't know if the amount of sex they're having or something throws it off.
Just don't know. I don't know that. I would not be able to answer that. So I mean, possibly. You know, I just don't know. I don't know. But this is actually one of the reasons why women should never douche. You know, we talked about that, did we? Never ever.
You don't know. You don't need to.
I just want to. You know, honestly, there are people can overuse areas and it's true, you can, and you can actually cause damage
When you
to
do
areas.
like porn or whatever, you're douching a lot because you're trying to keep everything.
Well, actually, people should never do. So I don't care what they're doing. So, but no, there's no medical reason for doing that. But yeah, so I don't know. I think anything that could lead to change in the normal flora or you know, which is kind of abuse, truly. Then it can change the normal flora. And so that's that would be something you would want to have happen.
Everything. Every time I say douche at work, I'm thinking of what you just said.
What?
Women not needing to douche.
When you see a douche at work, what you
No.
just say?
We sell. All right, I work in Dollar General.
Oh, you work in
Sell-
Dollar General?
Yes,
Oh,
we
you
sell
tell them,
vaginal.
when they come up to the counter and say, don't do that, it's really unhealthy. Like, don't
I know.
Run away.
I live like a.
It's
I live
really
in a
sad.
small area.
No, that's really very sad that women don't have enough. It's very sad that women don't have enough information out there for them to understand how bad that is for their health. No lie, serious. That is serious. So anyway, that's Gonorrhea vaginalis. But also, let me just say this. So the treatment, and you think, okay, so treatment in Flagyl, metronidazole is a common treatment for that. Sometimes women keep it so much that they end up going ahead and treating a sexual partner just to hope that maybe they're not just, you know, back and forth, but it's not considered a sexually transmitted disease. If somebody is keeping inflammation so much in this region, it can actually lead to some fertility issues potentially, because the inflammatory process can be damaging as well, right? So trying to resolve it is important, but then you think, okay, you're treating with Flagyl, an anti-inflammatory, which is, an antimicrobial, which is usually for protozoa, but it also can treat anaerobes, which this one is, but it's disturbing the normal flora. So then you think, oh gosh, you know, so it's really hard, and some women really have a difficult time getting rid of BV. It can be difficult for them, and no joke. Okay, so which group? Okay, I'll know which group I look at it. so protozoa, we got protozoa, right? We didn't have very many, did we? So Entamoeba histolytica. Well, so Jake should have done Naegleria fowleri. He had a pretty nice little PowerPoint. But anyway, so primary amoebic meningoencephalitis, it can lead to that. It is essentially 100% fatal. There's been one person who did not die from this, and that one girl that didn't die and didn't have neurological damage. That particular person had been, they used hypothermia as one of the treatments while also giving antiprotozoals. So it's essentially 100% fatal. The good news is that it's very, very, very rare.
Which one is that?
Naegleria fowleri. Naegleria fowleri. Now we'll go back to Entamoeba histolytica. This one would require history of travel. So, oh, it doesn't say that up there. But anyway, it can cause, this is amoebic dysentery. So this can cause, and when we say dysentery, that's different from diarrhea. What was the difference? Blood. And can people actually like bleed out even, or can it cause a problem that the mortality rates are higher in anything that can lead to those types of situations? So Entamoeba histolytica, Central and South America travel. It's in the water sources. And so this is why they tell people, you know, be careful, don't drink the water. You know, even don't eat salads because they've been washed with the water and you know, whatever. It's for two reasons, though, that people get told that. There also is a more virulent strain of Escherichia coli that causes that Montezuma's revenge. Have y'all heard of that?
Yes.
That's the E. coli. But then this one, too. This is a protozoa, an amoeba, isn't it? So, okay. Now, the other one is going to be Cryptosporidium parvum. Okay. So, cryptosporidiosis. This is endemic here in this area. This is endemic everywhere. Let me tell you, this is a protozoa that lives in like cow colons and intestines. So when cows poop, is it in the poop? Yes, it is. And then it rains. And then yeah, but it's mostly going to be oral transmission. So what it does is it rains, and then it rains, and it washes all the water to the lakes and ponds, and then your towns or your cities clean the water. So you know, before it gets sent out to you. But if the systems get overloaded, then some of these, okay, it's okay. It takes a certain infectious dose, though, so most of us wouldn't get sick from it. In Milwaukee, I think it was Milwaukee in like 1993, and I know y'all are thinking that's before I was born. There were hundreds of people sick, and quite a few died. Who were the ones dying? The very young and the very old. And so, you know, this is one that we kind of think about, but usually treated water sources get rid of this. And so, you know, it's the people who don't have treated water sources, wells, springs. And I think I asked y'all, did anybody have springs? Nobody drinks from springs anymore, do they? I grew up with springs, so I definitely had this. I mean, you know, whatever. You get over it.
That's back then.
I know. I remember being in parasitology thinking, of course, and thinking, oh my God, I had that. I know I had that one. All right, so let's see. Where are we? Let's do fungi, okay? So fungi is yellow here. Keep going. All right, see, I guess they chose another room. Are they still out there?
I think they put a sign on the door.
Oh, that's so nice. Okay, thank you. Michelle, take care. Thank you for presenting. Okay, so let's look at the fungi. This Pneumocystis jerebecki, this is actually going to be, this is the only time we're going to see this fungal infection causing pneumonia is truly in our AIDS patients. I mean, I've never even seen it in end-stage cancer patients. This is truly going to be full-blown AIDS. And sometimes it's the last thing they have because it's what takes them out. You get what I mean? So when this gets diagnosed, you just know this is bad. Aspergillus. There's a couple of different strains. Oh, good, I have one here. Fumigatus and Flavus. This Aspergillus is, again, a fungi, a dimorphic mold that is going to end up causing, if it's systemic, if it's been airborne and breathed in, so it's in the lung, it's going to cause a serious kind of systemic mycosis, and mycosis meant fungal infection, right? So usually some of these, what we think about is going to be people who are immunocompromised or have something that's already pre-existing, right? So whenever you hear about pneumonias or systemic diseases that are fungal, y'all know the treatment is much harsher. And you know that this is going to be something that's going to be much more serious, isn't it? Now, all right, so whatever. So y'all kind of seen that. And you saw where, like, the ringworm too. Okay. Histoplasma capsulatum. I really haven't talked about Spelunker's disease.
No.
Where have you been? Okay. Do you know what spelunking is?
Yes,
Okay.
I feel like you may have mentioned.
Okay, so Histoplasma capsulatum. Histoplasma capsulatum is a fungus that, again, we're going to typically see if somebody gets a huge inoculating dose because they've been in caves and bat poop has been dropping on them and they've been breathing it in. So they got this huge infectious dose, or they're young or old, right? And their body's immune system could not handle it. So this can actually cause very serious disease. I actually worked on a case with this with a little boy that died from this. So he had been from Southwest Virginia. He got sent up to us, pretty much DOA, in Charlotte, by the time he got to Charlottesville. But it was this, and he had gotten it. From the chickens in his yard. It is in bird droppings, it's in pigeon droppings, it's in chicken droppings, it's in bat droppings, it's in caves. It's called a Spelunker's disease because usually there's, if it's a young, healthy person, not like a little 6-year-old boy, but a young, healthy person that gets it, they have exposure because of the caves. So that's why it's called that. Histoplasma capsulatum. Okay, all right, great. We're good? All right, so now we're moving on. I've got to thank Reese and George for doing this for me. All right, so do we just add helmets? Really? Except for, and viruses. Okay, no, we did the viruses. Okay, so helmets, let's look at helmets. Those seem like a lot of these. We looked at these, though, in lab. And I really hope that you guys remember that we looked at these in lab. Anaerobius vermicularis is what we call pinworm, didn't we? We said a Scotch tape prep is what's used. They take a little sticky part of a clear tape and pat around the perianal area and look for eggs and or adult worms. Adult worms are going to be thread-like, really little ones that are like rice length and thread-like. So the adult worms don't get very big. The females lay their eggs in the perianal area. It's a very common, it's a very contagious, it can be very difficult to get rid of, and it's endemic in humans, and how do you get it? You get it by ingesting the eggs, ingesting the eggs, they end up opening in the intestines, so you just keep auto-inoculating yourself.
Yeah, one of my friends had that.
Yeah, and it can be difficult to get rid of because of that. You have to clean all the bedding and all the clothing. You have to be very careful to clean it all because, you can end up shaking sheets and then just inhaling.
Like, what did you originally ingest it from?
You would have had to have been in touch with somebody who had it, who who actively had it. And because it causes such intense perianal itching, they would have either scratched or whatever. They have it on their hands now, and you shake hands. Shaking hands takes on whole different things, risk factors. Don't in after class like this.
I'm keeping my hands to myself.
Okay. And huggers, I'm a hugger. And how many of you are huggers? Yeah, we maybe need to stop doing that. And then the whole, not really. It's all good. We're all friends, right? And these are, it's all good. So Necator americanus is what we call hookworms. Hookworms, roundworms, whipworms, these we see in pets too, don't we? We see these, and we understand these are ones that can be zoonotic. These are larger types of worms. Usually you don't have to use there's no question you're seeing these worms. There can be flukes, the Chlamydia sinensis, and schistosomatitis. I know how to say that. There's actually different, there's manzanite, there's japonicum, and hematobium. So there's different species of that, but they would require for that travel to usually Asia. I've heard people say something about Africa, but it's usually Asia. So there's a snail that's one of the intermediaries of the life cycle. So that would require travel. Some of these others would not require travel, except for Wisteria macrophy. Let's go down to that one for a second. The other ones you can just see. We don't usually see Tinea solium so much anymore because of what? That was huge when I was growing up, by the way. Tinea solium, this was actually kind of huge, and these larvae would migrate to mussels and encase in mussels. And you know, this had a significant mortality rate when I was little. But why don't we see it so much anymore? Pork tapeworm. Yeah, because there's inspection of meat now sources. So it's not like you're killing your hogs at home who've been eating the rats from your barn and just all of these. So it's not like a lot of people are doing that. Now you could actually see if people would inspect pork, you could actually see the little infestations. But still, people, if you're hungry, you'll eat it. Back in the day, people weren't as good about it. So now, though, meat's inspected, the way it's killed, you know, it's different. So anyway, we don't see too much of it anymore, but it's still out there. And it's actually, let me just say this, it's actually thought from immigrants that are coming in. And I'm sure y'all read this if you've read any in your textbook and stuff. It's really thought from immigrants coming into our country that haven't had that type of regulation of their food sources, that we are probably missing these diagnoses for some of these things in our immigrant populations. So please keep in mind, if you have patients that have recently entered into our country from areas where they haven't had benefit of some of these things, that you have these in your mind, that you're thinking that this could possibly be it. I think Jarrett was first, and that's coming to you, Molly. Yes.
You said that the Tinea solium can be in the mussels of pork?
Yes.
Okay.
So you're eating pork, you're eating the meat, and it's in there, and when you eat the meat, the larvae are actually going to open up, move through your system, and infect you.
Is that the thing that, like, I think I've seen videos of people pouring cola and eating the pork in it, and then eventually sometimes these little maggot things?
Yes.
Okay.
That's exactly right. That's exactly right,
I
Jerry.
cook my meat, girl. All the way.
He cooks his meat. Okay, everybody should be. If you're eating meat, cook it. Yes.
It's like if you cook it, it like kills.
Yes. Yeah, it can.
So medium rare doesn't count.
I eat a medium rare. I'm not drying out.
It makes you want to become a vegetarian looking at this list. Okay, so I actually want you to know the Wisteria macrophy, this causes elephantiasis. This is a lymphatic worm, and it's in northern Africa. So what happens is, so again, that would require travel history for us. If you had somebody here, it would require that. And it causes something known as elephantiasis because the worm gets into the lymphatic vessels and blocks the vessels, so that lymph that's bathing your tissues can't get returned to the bloodstream. So fluid that's bathing your cells gets trapped. And if you look up any pictures of elephantiasis, you'll see how trapped fluid can get. So you know, it's a real risk for treating, because when you treat any types of worms that may be in these particular areas and they die, then you've poisoned your system because they die. You've got these things that, so it can be especially challenging. We see much less of this than we ever did before, you know, because of progress as far as our meat processing, and because of whatever, we're just aware of it now. So how do you feel about those?
Are you
Are you
skipping
going over the animals?
What did you say?
Are you skipping the two that cause intestinal distress?
Which one did I skip?
The two above.
Oh, Hymenolapsus nana and Diphyllobothrium latum. Those we see in our pets, and so they can be transferred to us, and so we can see them. But you know, I don't think you'll see them very often. I really don't, because I think most of our pets now, people, you know, back in the day, Does anybody have any grandparents who have pets but they've never taken them to a vet and they've never warned them and they've never done anything to them? See, a few of you are nodding and some of you are looking horrified. Like, what do you mean they would do that to their pets? Okay, that's the way pets used to be treated. But now we have pets that we have that we don't get as much of this because usually they are on some, you know, they are getting older. Okay, so let's do viruses. Start off the
Yeah, I think
Oh, there's only two? Okay, good. All right. Okay, so hantavirus is deadly. Let me just say that. Hantavirus, did somebody do hantavirus? Hantavirus is a severe, it says acute, which is the same, respiratory failure. So it's considered to be an emerging disease, but that's not really true because hantavirus has been around for a long, long time. But what's really happening is that humans are encroaching mostly in areas that humans are more encroaching in these areas where it can be found. And so that's why we're seeing numbers come up, right? So usually, typically, we think about arid regions for this virus, and it can be in like rodent urine and whatnot. So people are going in like to very arid regions, and maybe like I think the last outbreak had some
Wild rodents or
wild. So they're going like the last outbreak I think, and I'm probably not accurate on this, but the last one I recall was like in the Southwest, and some hikers, some healthy adults with good immune system, but still doesn't matter. They went in and they were sweeping out a cabin to stay in, you know, because they were like hiking, whatever. And so anyway, they think that when they did that, they disturbed the urine and stuff, and so then they breathed it in and they got acutely ill. And by the time they could get to a place to be seen, it was because, you know, with viruses, you have to treat symptomatically, but it was almost too late. They were overcome by it. So early care, early treatment is kind of key for that. Yellow fever virus, causes yellow fever, but I think the reason I put this on here now is because there's some indication that Central South America yellow fever, like Zika virus, is going to be yellow fever virus. These are ones that we tend to think of in that region, but guess what? We're getting outbreaks now where? In our country too, and so the numbers of this is on the rise, and so just wanted you all to have at least heard about it. Okay,
You have that on your 20s for arboviruses.
yeah, probably. Okay, so
Are we going to go over the vectors?
are we gonna what?
Go over the vectors.
Yeah, so these vectors, you know, I think we had talked about a little bit, like Anopheles mosquito causing malaria, the females that feed at night, right, that end up transferring malaria. We know malaria was caused from a protozoa. But these vectors, a vector is just anything that can help transfer or carry disease. And so some of these I really did want you to know about.
Why do we have rats on here?
I know, we know and humans are vectors. Like I should have started with humans. America's humans are vectors. That's what we did. But anyway, so this was just some that I thought that you might not have heard of, because I know you've heard of ticks and whatever. But scabies, scabies is not uncommon. So people will get scabies, and actually, again, sarcoptic mange in pets, you've heard of, haven't you? But scabies in humans is also something you see, and you'll see a typical kind of lesions that are going to be around the fingernails, because people will scratch and cause what is described as intense itching. It can be around the bands of clothing. It's very contagious between people. So, bedding and all that. But with a diagnosis for this, sometimes it can just be the lesions. But you can take a little, like if there's like a little trail of the lesion, you can scrape the skin off and do like a wet prep. And if you see the scabies mite, then it's diagnostic. It's going to take head to toe treatment. It's going to take treatment of clothing. It's going to, bedding and everywhere. And I didn't put human lice on there either, but you know, it's usually because you can see lice, right? And you can see those, but these little ones that cause scabies, you need a microscope. Chiggers. We've all had chiggers, haven't we? You've never had chiggers? Well, you've never been in a field? I know. Have you guys before?
Yeah,
True story. I go to college, you know. Country girl go to college, and I have this roommate who's an only child. I'm one of eight, right? And she always has flowers in her house. But anyway, one of the flowers, I'm thinking she has like chiggers in her house. And this thing, I'm thinking, why does she chiggers? Because my whole life was told, get out of the chiggers, right? I thought this flower, I'm 18 years old, I think this flower is called chiggers because that's what I was told to get out of. Honestly, it's the Queen Anne's lace. Y'all know what Queen Anne's lace is? What you said? It's so pretty, but let me tell you, when it's growing wild, it's got chiggers in it. Monday at 12. Monday at 12. Thank you guys. Thank you guys. Gosh, everybody's running out of here. People need a break.
Weren't you going to hand out the take-home test?
What? Yes. Nobody wanted them, I guess. They're going to get them, I guess. Tell Jenna, yell down the hall and tell her she's got to get me those.
Be sure you get her your take-home test.
Oh, thanks.
Be sure you give her your take-home test.
Here's Jared.
I know that it's like.
Send it to me. I need it today, Jenna. Thank you, Jenna. Okay. Hey, Jared, thank you.
Did I make you miss class? Go to class.
I'm not going to class now.
Tell her why.
No, I emailed her and I told her I was in here. That we started late because the computer was shut down.